Greetings from Kenya. It's good to be with you. The title of this talk came from an experience I had with two Kenyan friends. We were traveling from Kenya to Malawi, where my family had just moved. We were taking our vehicle and our family's belongings. And as we traveled through Tanzania and northern and central Malawi, I looked around and I didn't see a lot of hospitals or clinics. And this question, where do people get their medical care, was one that has always stuck with me, has always really haunted me. And by where do people get their medical care, I mean also where do they get their compassionate and quality medical care? Clinics that are well-staffed with well-trained healthcare workers, pharmacies that are well-stocked, good functioning equipment. And this has been a question that's really animated my time in Africa to a great extent. When I was in medical school, I took a year off to volunteer in India. I really felt the Lord leading me to do that. And when I came back, part of me thought, well, I've done my time. It's time to get back on the career track and see what professional opportunities and successes are out there for me. But the Lord didn't let me sit comfortably with that thought for long. I really, again, palpably felt the calling to become a medical missionary. And so during my residency, and as you can imagine, there's not a lot of free time in residency, but I used my free time in residency to surf missionary websites and try to learn more about medical missions in Africa. And I came upon this place in Kenya, Kijabi Hospital, and made connection with a Dr. Nate Smith. His wife, Kim, was an OBGYN at the hospital, and Nate was an infectious diseases doctor who was starting some of the first programs to try to deal with HIV and AIDS in Kenya, particularly prevention of mother-to-child transmission. And Nate offered to me that he and Kim were going on an extended furlough, and he invited me to come out and really take his position at the hospital as an infectious disease doctor and in the HIV ministry. So that sounded like a really good fit for my background and calling. And before I went, I was offered a job that was really kind of my dream job. But the verse where Jesus says, "He who puts his hand to the plow and looks back is not fit for service in the kingdom of heaven," really struck me and convicted me that I had been called to do this work. And so I turned down that opportunity. Now, I wasn't really sure what I was getting into. I was not really well prepared for what awaited me in Kenya. I knew that I would be caring for people with HIV. I knew that I would be practicing infectious diseases, things that I knew something about. I was really surprised that I ended up working so closely with the surgeons. I had never really considered the surgical problems in Africa before, and so was stunned at the vastness of the problem. I was also involved with taking care of kids and doing intensive care type work in a resource limited setting. This patient brings a lot of those experiences into focus. And in one case, he was a young boy from a nomadic group in northern Kenya who had been attacked and mauled by a lion that had already killed a couple of people. And by the time he ended up at Kijabi Hospital, he was in septic shock. And I remember rounding that morning. It was a Saturday morning, and I was done with my rounds, and I saw this child in the high dependency unit and thought, well, no one's asked me to see this patient yet, so I'm tired. I'm just going to go home. But it didn't take long before one of the surgeons called me and asked for my help. And this is a BiPAP machine that was actually brought to my wedding and left with the hand towels and the china. Those things remain back in the States, but we brought the BiPAP with us, and it helped us to take care of this child. We didn't intubate a lot of patients back then. I was at least expecting more patients like this one, a 17-week pregnant mother who weighed 33 kilograms and was infected with the HIV virus. She was in denial. She thought that her condition was due to something called hydatid cyst disease that's common among her ethnic group, but it was really advanced AIDS. And we admitted her to the hospital, fed her through a nasogastric tube for weeks. She was in the hospital for a month. We got her on antiretroviral therapy for HIV infection. She had disseminated miliary tuberculosis. We treated that as well. It was a lot of juggling of medicines. She did improve. She gave birth. At some point, she probably rolled over onto the baby and his hip broke. He spent a couple of weeks in the Kijabi nursery. But I'm so pleased to be able to say that she's still alive today. Just this month, one of my colleagues made contact with her, and she's doing well and still on the medicines. But back then, there were so few resources at the hospital for caring for a patient like this. This was before the President's Emergency Plan for AIDS Relief, the George Bush initiative to treat HIV in Africa. So we had few trained personnel, and we had very few resources and medicines. And I used to sit in the clinic. We were treating some people for HIV infection with antiretroviral therapy at that time. And I used to sit in the clinic and wonder, why are people late for their appointment? I told them that these medicines, if you miss them, it can cause resistance or you can get other infections. But really, I was naive and maybe more than a little bit arrogant, or at least out of touch with the people that I was supposed to be serving. And I didn't at that time know that this was the reality for many of our patients, and that even getting to the hospital was financially and logistically extremely difficult. It wasn't that they didn't want to come. It's just even coming to the hospital, much less paying for the care once they got there, was so difficult. So, when you face conditions like this, and you have so many patients like the one that I just showed you, how do you confront such a problem with such limited resources? Well, fortunately, during this time, the PEPFAR program began to scale up, and Kijabi was one of the hospitals chosen for assistance. And one thing that I had learned was that you need to get out into the community. I had a patient, a girl of about 6 years old, who had brucellosis. It's a milk-borne bacterial disease, and she'd been pretty sick, but she had recovered. And when I was speaking with her mother, she said, well, we have a couple more family members back home who are also sick like this, but we couldn't afford to bring them. And I just thought that was unacceptable. This is a treatable disease. We need to do something about this. So I went with the hospital's credit officer, a wonderful man named John Correa, whose unenviable task was to circulate in the community and try to have patients pay what they owed the hospital. And he knew this area, and we went out to visit this family. It took us hours along muddy roads to get there. And we did find another family member who likely had brucellosis, and we saw the very sick cow. But that opened my eyes to the reality that so many of our patients were living in and experiencing. So we knew we had to get out into the community, that we couldn't just sit back and wait for patients to come. So we started support groups. This is one of my very favorite places, called Thagio. And we had great partnerships with churches and pastors. And later we trained patients as community health workers to really prepare people and the community for lifelong HIV treatment. And it was really a great success. When I later moved back to the US and was working in an HIV clinic in Texas, I asked one of the social workers, don't you do home visits to find out what challenges the patients are having or why they're not taking their medicine? She said, yes, we'd love to do that, but the hospital says we cannot because of legal liability. So, visiting homes fits with African culture so well. If we visited 8 homes in a day, you could be sure you were offered at least 8 cups of Kenyan chai, which was more than I could drink. But this was clearly a part of addressing this problem. Another part of the response was training local health workers. When I first got to Kijabe, there were very few people with any experience treating HIV infection with these medicines. And it became clear pretty quickly that I would need help. And so I started training some of the hospital staff, and we built up a great clinical team. Here's our early clinical team. On the left is Kenneth Mariti, who's been a close friend for a very long time, and now is the vice president with our organization. He's a physician assistant, so is Nancy in the middle. She went on to be an anchor in a Doctors Without Borders HIV clinic in a Nairobi slum. And then Dr. Ivy Mwangi, who's just a spectacular clinician who's now an internist in the United States. And we had many others, clinicians and nurses and counselors who we trained and worked with, and were just wonderfully compassionate people who made this effort a success. So, at the end of 4 years, it was very tiring. When I first got to Kenya, it was kind of like just an extension of my residency, and it was like doing another 4 years of residency. And we needed a break, and our family, we moved back to the U.S. for a time as we tried to discern the Lord's will for the next phase of our lives. And we had the good fortune of hearing about some work in Malawi. Dr. Perry Jansen, who now works with our organization, but he and his family spent 16 or 17 years in Malawi and started this ministry, Partners in Hope, focused particularly on caring for people in Malawi with HIV infection. And they were looking for an HIV clinician educator, and that's really a good fit for me and my background. So we ended up moving there at the end of 2008. And we were really able to draw on some of the lessons that I had learned in Kenya about community involvement, training community health workers and counselors, and really supporting patients in a holistic way. Well, Partners in Hope was growing actually quite rapidly in the numbers of patients and the types of services that it offered. I was continuing to teach and see patients. And then a friend of mine named Mark Gerson, who's spoken at M3 before, whom I'd known since college and had supported our work, he and I co-founded an organization called African Mission Healthcare in 2010 to come alongside mission hospitals and really help them not just survive, but thrive. Back in 2006, while still in Kenya, I had traveled around helping mission hospitals set up their HIV clinics. And we just saw a lot of people doing heroic work, wonderful people, but without the resources they really needed. You would say we want you to put 1,000 patients on antiretroviral therapy over the next year. And they just gesture and say, okay, we have these 2 rooms here, so we'll try to do it in these 2 rooms. Or we want to give you some lab equipment to monitor HIV infection. They'd say, here's our lab, the old dusty place, the size kind of a large closet. And they just didn't have the resources to really expand and address these problems. And so that really stuck with me, and some other supporters along with Mark and I founded this organization. At the same time, my own family was growing. My 3 children, who are younger at the time, are shown here. Anna's our youngest. She was born in Malawi. And Matthew is our oldest. He's in the middle. He was born in Kenya, and Aaron was born in Texas. And here they are at one of our very favorite places in the world at Lake Malawi. And it was just becoming very difficult to juggle all these things from Malawi, which is not a central location. So we decided to move back to Kenya, which was closer to a number of our partners. African Mission Healthcare works with a lot of different types of hospitals and people and projects. One of our major and best known initiatives is called the Lahaine Prize for Outstanding Christian Medical Missionary Service. Lahaine stands for To Life. And this prize was founded by Mark and his wife, Rabbi Erica Gerson, just phenomenally generous people. And it's a $500,000 a year annual award, not really to an individual, but to the winner's hospital to affect life-changing care and transformative projects. And the top center is the first winner in 2016, Dr. Jason Fader, a surgeon, and that prize helped with surgical capacity building and intern education. In the top right is Dr. Russ White, who's also spoken at M3 before. He's a cardiothoracic surgeon in Kenya who started a general surgery training program, has been in Kenya for about a quarter century. And he just celebrated the graduation of the first African cardiothoracic surgeon out of the Tenwik training program that this prize helped to launch. And now we're working with Samaritan's Purse and Dr. White and Tenwik to hopefully further enlarge the cardiothoracic program. In the bottom right is Dr. Rick Sacra of Liberia. He's been in Liberia for decades. He did contract and survive the Ebola virus in 2014. And for years, through years of civil war, Dr. Sacra wanted to found a family medicine residency program to train Liberians as solid generalists. And so the prize is helping with that project. In the bottom center is Dr. Tom Katina of the Nuba Mountains of Sudan and his wife Nasima, a nurse, and their son Francis. And that's the only major referral hospital functioning for about 1.5 million people. And it's the only place you can get surgery, get a C-section, and they're starting a health training institute. And in the large picture to the left is Dr. Sister Priscilla Businji, who is the 2020 winner of the prize. She's a Ugandan nun and an OBGYN and an accomplished fistula surgeon whose prize application was for building a maternal health center of excellence in training in southwestern Uganda, where we've worked for a few years. So we're so privileged to have the opportunity to work with people like this, to try and help them, to work with their facilities, and many others who we've not been able to award the prize to yet, but we're looking forward to many years of such partnerships. Also under what we call the Lahaine initiative, there's the Lahaine Prize, and then there's the Mission Hospital Teaching Network. The MHTN is initially focused on 2 hospitals that received $2.5 million grants over 10 years, about $250,000 a year, to enhance institutional sustainability and medical educational initiatives. One at Kibuye Hospital in Burundi, where Dr. Fader is, and another at Nkoma Hospital in Malawi, the first and third poorest countries in the world, respectively. And Lahaine is a Hebrew word meaning to life, and the purpose here is to train many, many more competent and compassionate Christian African healthcare workers to reach out to others, to care for others, and to teach and train others. And this top picture from Kibuye just really gives a sense of the opportunity that's there. I like to quote Dr. Bill Rhodes of Kapsawara Hospital in Kenya, and he says, we just really need to reach out and grasp and see what the Lord is offering us. There's just the opportunity to mentor and disciple and give opportunities to so many bright young African healthcare professionals. And here you see so many learners and students craning, trying to get their chance to learn from Dr. Fader, to see what's going on with the surgery. So you need more space, you need more faculty, you need more opportunities. And in the lower right is the first class of interns in the history of the country of Burundi. Before this class, after medical school, Burundian graduates would go straight into practice. And now at Kibuye, they undergo an internship. That internship has since been expanded under the MHTN and has been extremely successful, both for the interns and to help the hospital deal with an increasing number of patients. In the bottom left shows the laboratory at Nkoma Hospital, which we helped renovate about 5 years ago. It was really a dusty, kind of dingy place, not very hygienic before. And after it was renovated, the faculty from the Technical Health College in Lilongwe came out and said, boy, we'd love to send you lab trainees out here to work in such a place. And, there's just so many opportunities to touch so many lives and provide opportunities for young learners. Another area in which I would have never thought I would have been so involved, I touched on it at the beginning of the talk, was surgery. Just like I had worked so closely with surgeons after arriving in Kenya that first time, I actually also realized that surgery was what was keeping the hospital open. My patients, poor medical patients in a coma for 2 weeks, failing to pay their $250 bill, I was trying to figure out, how does this place stay open? And it was obvious that surgery was a big part of that, and that there was an enormous unmet need. Now, I'm an HIV doctor and an internist. I'm about 10 minutes a stitch. So if you see me with a scalpel or a suture, you probably want to run in the other direction. The writer William Easterly talks about two types of people who work in these settings. One's a planner and one's a seeker. So you can make all kinds of plans, and you should make some plans, and you should have some idea of what you're going to do, but you can't rigidly stick to those plans. You have to adjust to local circumstances, needs, and goals. And surgery for me is an example of how you need to be a seeker. You need to be alive to what the other needs are that are going unaddressed and unmet. So we have been involved in sponsoring surgical education. This is Dr. Tony Mwanyamale in the center at the top. He trained under the Pan-African Academy of Christian Surgeons at Mbingo Hospital. He himself is Congolese, and he's now working in Kenya. I had the chance to work with him for a couple of years, a fantastic surgeon. We sponsored his training. In the lower right is a woman whose C-section for twins was sponsored by us in southwestern Uganda. We have several partners there where we have this program because not enough Ugandan women can access C-sections. In the lower left is the sluice area, quote unquote, of Niachibali Hospital in southwestern Uganda. So it's not, of course, a room. You can see a nurse in very unhygienic conditions trying to clean the surgical equipment after a procedure. Of course, they would have put it into autoclave before going back into the theater, but it's less than ideal, to say the least. And so we helped the hospital renovate their whole operating theater complex and gave them a nice new sluice as well as other areas. So, this is one area where a lot of mission hospitals can really make a contribution. They have systems, they have a legacy of infrastructure and longitudinal presence in a community. It's something that a lot of other groups can't do. And so it's something that we've gotten involved with pretty significantly. This work simply wouldn't be possible without a great team, and AMH has a wonderful team. We have a few people in the United States, but most of our team members are in Kenya, where we have an office. And, pre-COVID and hopefully post-COVID, we do travel a lot to visit our partners and develop these strong relationships. So I'm very grateful to you for the time to share, and I'm very grateful to the Lord for the ministry that he's given me over 2 decades in Africa. And I'd encourage you to think about your role in long-term medical missions. Thank you.
Well, a very practical and detailed look at medical care from Dr. John Fielder, who is the Chief Executive of African Mission Healthcare. We're excited to welcome him to us live via video. Welcome, Doctor. Good to have you here.
Great to be here. Thanks, Chuck.
Yeah, and welcome, John. At 5 in the morning and there in Kijabe, Kenya, right?
Yes.
Well, thank you so much. John, we both share a passion for Christian mission hospitals, and it's just really hard to contextualize for people who don't know care in the remote areas of Africa. Can you kind of put that into perspective, what these hospitals have been doing 50 to 100 years now in caring for the poor people, providing quality, timely, available care in these remote areas?
Yeah, well, you mentioned Kijabe. It started in 1915. Another hospital partner of ours in Malawi called Nkoma Hospital also started in 1915. where I spend my clinical time now. MOA Hospital began in 1928. I mean, it's pretty out there now, but you can imagine what it was like in 1928.
Right.
There's a great photo at Kijabe of Dr. Barnett, the founder of the modern hospital. It must have been about the 1950s. And he's dressing someone's wound on a hillside.
Wow.
And, that's just the kind of hands-on care that's, of course, without these mission hospitals would not have been available to people. And they have really deep roots in their communities and a legacy that, like you said, goes back 50, 75, 100 years.
What's amazing to me, John, is that you go to these remote areas and you may find a government, clinic or, a poorly resourced, maybe small hospital, but very often you'll find vibrant mission hospitals in these remote settings. Is that what you've seen?
Absolutely. People, as Pastor Oscar of Nairobi Chapel has said, the missionaries came and they had their model. They went to a rural area. They planted the church, they started the school, and they started the hospital or the clinic. And so you have those mission stations historically dotted all around Africa, particularly in the rural areas. And it's been, a lot of sacrifice by both missionaries and their African Christian colleagues to keep those places going.
John, you mentioned the Lakewood Award, and you also mentioned, I forget which award it is, the $2.5 million over 10 years, but I just want to personally say I don't think people realize what $250,000 per year for 10 years will do to a mission hospital that's been struggling for years. And so tell us a little bit about that. I mean, is that your perspective as well? I can't imagine what this is going to do for Jason Fader and the group in Burundi and the people in Malawi. How will this elevate the care and the ability for these hospitals to function?
The idea behind the Mission Hospital Teaching Network was to come alongside initially what we were calling, emerging mission teaching hospitals. Maybe they did a little bit of medical education, but really had plans or were starting to do postgraduate medical education and other special programs. And we're in the process of expanding that now to adding more sites to the network. And adding some of the more mature mission hospitals as well, places like Kijabe Hospital, Tenwick Hospital, although at a little bit lower level. But the idea is to come alongside and listen to what their needs are, because each hospital is going to have different needs. I'm an HIV doctor, and that's my specialty, but most of these places have pretty well-resourced HIV programs, so we don't just come in and say, well, we're here to help you with HIV. We listen to what their needs are. And then with those kinds of resources over 10 years, it really allows people to plan and to think ahead about, if we want to get, down the road, what do we need to do before we get there? And so it's a consistent provision of resources that can meet a whole different variety of needs, from training a family medicine resident or a surgery resident to equipment to building housing. So that was the idea behind the Mission Hospital Teaching Network.
Yeah. Dr. Fielder, we have a couple of questions that have come in from some of our viewers, but before we get to those, let me just mention, if you're just joining us, one of the unique things that we have at M3 this year is the opportunity for you to ask questions in real time and have our guests answer them. Right on your screen as you're viewing, you'll see the Q&A tab. Make sure you click on that. Ask your specific question and we'll do our best to get it. In fact, Dr. Fielder, one of our questions comes from Alan in Arizona, who I believe might be a friend of yours, Dr. Paul. But it's a great question. What's the status of COVID vaccines, and is that becoming available in sub-Saharan Africa?
Yes, that's a good question. It does vary by country. The vaccines are just starting to arrive. There was a shipment into Kenya, I want to say just in the last week or two, of the AstraZeneca vaccine. My admittedly limited knowledge is that they'll start at some of the bigger referral hospitals as distribution centers. I haven't heard that happening yet where I am, but I believe that that's the plan. And then some other countries, I saw just the other day that Ghana has started to receive vaccine. South Africa received some AstraZeneca vaccine, but then they had done a study because of the South African variant that maybe the AstraZeneca vaccine wasn't right for South Africa, so they've now switched. I'm not sure which one they're using now, but some programs have started.
Yeah, really unique on the ground perspective, I think. Another question, very practical. How do you, what are some of your experiences and how have they been when you're sharing Christ with those around you in the mission field?
Well, I've worked a lot with trainees who are already Christian, and I have really tried to come alongside them. And I mean, they've discipled me and mentored me spiritually more than I have done them. What I've been able to bring to our mutual relationship is really the skills and the background that I have as a clinician, because sometimes they may have come from medical educational institutions where they didn't have the opportunity for a lot of close mentorship. So I see my role as coming alongside them and empowering them as rising and influential Christian healthcare leaders.
You go there as a missionary and you get you're the one that receives a blessing. I hear that story over and over and over, I think, from those serving in the field. Yeah, we appreciate that. Well, we appreciate you joining us for this quick Q&A session. Dr. Paul, I understand he's going to be with us tomorrow as well with a presentation?
Yes, tomorrow in a breakout session. He's going to be speaking as well. And we'll also be talking a lot more about African mission healthcare, and just excited about that session tomorrow.
Well, one of the things that you can find on our website is the schedule, everything that's going on for the rest of today, this evening, as well as all day tomorrow. So many great resources on our website. Make sure that you take advantage of those. Dr. Fielder, thank you so much for joining us for this quick Q&A session. We appreciate it.
Thank you, John. Have a good day.